All right. Welcome, everyone, and thank you for joining us for HealthRIGHT 360 Insiders Update. My name is Brian Graham, and I am the chair of the board of directors of HealthRIGHT 360. I joined the board because of my strong belief that everyone is entitled to healthcare in this country. We welcome everyone through our doors for compassionate, non-judgmental healthcare, regardless of their ability to pay. Our belief is that healthcare is a right, not a privilege. Last year, we took care of over 40,000 people, 80% of whom are experiencing health homelessness. In addition to our medical and dental clinics, we provided substance use, disorder treatment in residential settings and have over 550 beds in San Francisco and 1,500 beds statewide. Before Vitka begins her presentation, please welcome tonight's moderator, Ahmad Thomas. Now, Ahmad is a CEO of the Silicon Valley Leadership Group and one of our board members. So I'd like to welcome Ahmad and have him take over from here. Thanks, everyone.
Thank you so much, Brian. Thank you for your leadership on the board and all of your hard work. It's a real pleasure to serve with you and support this wonderful organization. Thank you all for joining us tonight. I want to make sure right up front, we thank our generous partners, Barclays, Kaiser Permanente, Salesforce, Sutter Health CPMC, Twitter, UCSF, and Verizon. Thank you so much for your support. As moderator, my role tonight is to help facilitate our discussion with Vitka. You'll see there in your center panel on Zoom the word chat. If you click the chat box, you can pull up my name, Ahmad Thomas, as moderator, and send your questions early and often throughout Vitka's presentation. Don't wait until the end. Fire the questions as they come to mind, and I will be sure after Vitka concludes to ask the questions that you all provide. And I've got a few questions of my own as well, and probably more that'll bubble up as we listen to Vitka. Now it's my pleasure to introduce you to HealthRIGHT 360's President and Chief Executive Officer, Dr. Vitka Eisen. She's dedicated her life and career to supporting people and communities struggling with addiction and incarceration through integrated, compassionate, and relevant healthcare. Vitka earned a master's in social work from San Francisco State University and a doctorate from the Harvard Graduate School of Education. She is a former injection heroin user who over 30 years ago participated in the substance use disorder treatment program at the organization she now leads. Just an incredible story from a passionate, very successful, and very, very effective leader. Thank you, Vitka, for all that you do. And I'll now turn it over to you for your presentation.
Ahmad, thank you so much. Thank you for the introduction, and Brian, thank you as well. Thank you everybody for joining us tonight. We had really envisioned a warm living room conversation amongst our friends and supporters. So this is one of the many ways we've all had to adapt to our new reality. Yesterday it was bizarrely orange, and it was like end times. I've never seen anything like that. So today it's not orange, but the air quality is horrific. So again, seems to be our new reality in this surreal existence we have. But I wanted to have a conversation with all of you that looks at HealthRIGHT 360's work providing treatment for people who use drugs within the context of the Black Lives Matter movement, and with the growing national acknowledgement of structural racism and police violence against Black people. When we use the term structural racism, we're referring to a system in which public policies, institutional practices, cultural representations, and other norms work in various ways, often reinforcing ways to perpetuate racial group inequity to the advantage of white people and the disadvantage of Black and brown people. Structural racism manifests in economic policies, employment, housing, banking, education, environment, healthcare, and most relevant to our conversation today, to our understanding of law enforcement and policing, and specifically the murders of Black people by police. You can trace our interaction. We have a complicated substance use disorder treatment, and substance use has a complicated history with the police and with law enforcement. And you can trace that back to the war on drugs. In the 1970s, Nixon declares war on drugs. And in following that, in 1986, Reagan introduces a crime bill that includes mandatory minimum sentences in civil asset forfeiture. Now, these mandatory minimum sentences had a disproportionately negative impact on Black and brown communities. Mandatory minimum sentences, for example, could be handed down for simple possession of drugs or possession and sales. These meant that people could do lengthy sentences, 3, 5, 10, 25-year sentences in jail or in prison. And it was not up to judicial discretion. They were mandatory minimums for sentencing. And civil asset forfeiture following that meant that not only were people being sent to prison, but you could lose your home, you could lose your car, you could lose anything you had, like your business, any way of kind of making a living. So you can imagine the impact that has when those laws are applied disproportionately to communities of color. What happened between the 1970s and the 2000s is we saw a massive ballooning of the prison population. It increased by 900% in that period of time, to the point where the United States has the highest incarceration rate per capita in the world, higher than, you can name any other country. You think China, maybe. You might think Russia. Maybe you think Iran. Wherever you might think, the US has the highest incarceration rate per capita in the world. And California has the third highest rate in the world behind that, or it did until most recently. It did until the early 2000s. It had 177,000 people in prison. 122,000 people were on parole, not counting all the people in jail. You may be familiar with the work of Michelle Alexander. She's a scholar who wrote the book called The New Jim Crow, Mass Incarceration in the Age of Colorblindness. So to quote Michelle Alexander, she says, "Nothing has contributed more to the systemic mass incarceration of people of color in the United States than the war on drugs." What does that mean? Nearly 80% of people incarcerated in federal prison for drug offenses are Black or Latinx. About 60% in state prisons, 80% of the prison population, federal prison population. And prosecutors are twice as likely to pursue mandatory minimum sentences for Black people as for white people charged with the same offense. Many of you are aware of a policy that was changed under the Obama administration, in which there was differential sentencing applied towards people, whether they were in possession of crack cocaine or powder cocaine. The same substance, it's all cocaine, derived from coca. But crack cocaine was seen as something that was found more in Black communities, powder cocaine used amongst white people. So in possession of similar amounts, vastly disproportionate levels of sentencing. That policy was not changed until the Obama administration. Mass incarceration has an impact beyond the individual's lives that may be destroyed. It destroys families and communities. 1 in 9 Black children has an incarcerated parent, as compared to 1 in 57 white children. 2/3 of incarcerated parents are in custody for non-violent offenses, including drug law violations. And what happens with people who have drug law violations is that those history of incarceration and drug law violations follows them in their life and impacts them once they get out. So it impacts the ability to retain and maintain child custody, voting rights. Even in California, people on parole are not able to vote. There's actually a ballot initiative on the ballot in November that will restore voting rights to people on parole. But in other parts of the country, Florida, for example, even if you're off parole, if you have ever been convicted of a felony, you're permanently disenfranchised. Again, the whole notion of the new Jim Crow means that if you're disproportionately imprisoning Black people and then you're taking away voting rights forever in the state of Florida and other states as well. It used to be Virginia, I think they overturned that. Has an impact on an individual's ability to get employment, to get business loans, to get student financial aid, to get professional licensing, certain licenses you can't get if you've ever had a felony conviction. and it has an impact on a person's ability to get access public housing. This number kind of blew me away, especially when I thought about the murder of Breonna Taylor. 62% of SWAT deployments are for drug searches. SWAT deployments are traumatic and they're risky and they're dangerous. They're dangerous for everybody involved. And as you can see in the murder of Breonna Taylor, resulted in the death, the death of a young woman. 62% of them are for drug searches, not for hostage situations, for drug searches. And they're definitely traumatic for if there's children in the house, if there's seniors living in the same family. They're very, very risky and traumatic. Now, one of the things that happened at the point of time when we started incarcerating tons of people for their drug use is that eventually policymakers began to think maybe this isn't the best policy. Because one of the things we noticed when we incarcerated lots of people for drug use, the amount of people using drugs didn't go down, the amount of crime didn't go down, it didn't improve public safety, but it did increase a massive prison industrial complex. So we began to see the introduction of drug courts. Now, drug courts are places where people who are arrested for crimes related to drug use or for drug possession, drug sales and possession, can be diverted to a drug court. In the drug court, if they're required to participate in a treatment program, if they participate in a treatment program, that felony conviction can be overturned into a misdemeanor. If they don't participate in the program, they can be subject to flash incarcerations or just being sentenced and being incarcerated. So there's early research on drug court said, hey, drug court is good. There's some people for whom it really helps. I've certainly known people who will say drug court, but not for drug court, I would never have gone to treatment. So those stories are true. But when you look at the research broadly, research on drug courts has not demonstrated cost savings, reduced incarceration, or improved public safety. And they have made the criminal justice system more punitive towards addiction, which is a health condition. As I've said before, you might have even heard me say this. It's the only health condition for which we think going to prison is the answer. When people who have diabetes, like we don't think about sending people who have diabetes to jail because they ate donuts, right? But that's what we do with people who have a substance use disorder. The other issue with the other problem with our relationship with the criminal justice system is substance use disorder treatment providers. The relationship is complicated and it's problematic because obviously what happens is we become reliant on coercion. Like for the longest time, people came to treatment because a lot of people came to treatment because they had to. So when you have a system that's reliant on coercion for care, you have to ask yourself, what other business would operate that way? Like what other business? Like you ran a restaurant and the only reason people came to your restaurant is because they go to jail if they didn't. That would be kind of a ridiculous business concept model for a restaurant. And if people came to your restaurant and they ran out because the food was bad, you wouldn't say they weren't ready for our food. You would say maybe there's a problem with our food. But in substance use disorder treatment, because the courts have sent so many people there, that the programs relied on coercion to keep people in program. That stifles creativity, innovation, and truly meeting people where they're at. And it also means it builds up this relationship, which I think is not always healthy with the criminal justice system. It supports a notion that the only way to get people into treatment is to put them in jail, instead of saying, maybe we should do something different. So there are things that we do different, right? There are things we know that are alternatives to coercion, that are alternatives to locking people up as well. And some of those things are low barrier services. For example, we at HealthRIGHT 360, when we started a dental clinic, we really saw dental clinic as a low barrier service. We said, how do we access the people for whom we're not accessing? How do we reach those people? And maybe they're not coming in for healthcare, and maybe they're not coming in for substance use treatment. But you know what? I bet you if they have a toothache, they'll come in for care. And then once you come in for dental care, you link them to other services. You link them to healthcare, and maybe they come in for some treatment. Maybe we get them on medication-assisted treatment for their opioid use disorder. Maybe we get them on medication for mental illness. Engage them with care. Syringe access programs, also known as needle exchange. Those are other kinds of low barrier services. Needle exchanges where people come and pick up supplies to use, safely use drugs and not necessarily have to share syringes and transmit bloodborne illnesses. Drop-in centers. I had the opportunity to visit a drop-in center in Canada, which was for people who were marginally housed or not housed at all. They could come there for the day. They get 3 hot meals a day. There was showers. There was laundry. There was a medical clinic there. There was a range of services, mental health services, arts. There was pottery. There was movement classes. People could just spend time there. And what that meant they weren't on the streets. And it meant that they were connected, like they had a connection somewhere. When people have a connection, you can build health through connection. That's how we build. That's how we build. That's how we do the work we do. We build relationships with people. We build connections. We build health. Supervised drug consumption services. You may have heard in San Francisco, the mayor and the board of supervisors support the idea of supervised drug consumption spaces. We have a picture right here. This image is actually of a supervised drug consumption space in Berlin. And so people in supervised drug consumption, people bring drugs that they've obtained outside into the facility. They use drugs under the supervision of trained peers and health workers, so that you can make sure that they don't die of an overdose. They don't have no bloodborne illness transmission, abscesses, things that you can but mostly you're just like really connecting with people. That's why we do it. And finally, just integrated primary care. These are alternatives to coercion. People come in for healthcare. They come in for a rash, and then the next thing you know, they're at the food pharmacy and they're getting some food, and then they're getting access to a therapist, and maybe they come in look for housing, and then they're coming in for treatment, and we're getting them on medication-assisted treatment, and we're giving them help. So these are alternatives to coercion that we can exercise if we begin detangling ourselves from the criminal justice system. And finally, decriminalization. I mean, that is, that's one path towards moving away from a system that relies on policing and the criminal justice system to connect people to care. So that's a little bit about our work. We're really involved in looking at alternatives to police involvement. As an organization, we're engaged in San Francisco's. We're actually sitting on the mayor's steering committee on alternatives to policing for people experiencing mental health crisis and substance use disorder. So and we see that as very much a part of our equity and justice healthcare mission. With that, I'll stop talking and take any questions you have.
Thank you very much, Vitka. That was a very informative presentation. A lot to unpack, and I'm sure a lot of good questions that folks have, questions I have as well as follow-up. And I would just remind everyone, if you look down there at your middle panel, you see the chat button. Click chat. Ahmad Thomas, moderator, that is me. Highlight my name, and please share any and all questions that you might have. I will kick it off, Vitka. You talked about the war on drugs, the crime bill in the 80s. Can you speak to the relationship between crime and drug use? If we look at San Francisco, we look at large cities, I would assume with more violence and crime, there's more drug use. Can you speak to that relationship and the correlation?
Sure. So this is how we look at it. If you criminalize drugs, then you've already created a whole class of criminals. That is, people who use them, people who possess them and use them. And if you look at that from a historical, so you have a bunch of people breaking the law. You look at it from a historical perspective. You go back to Prohibition in December of 1919. If you had a drink, you were at a bar hanging out, or you were at home, you had a drink. And then in January of 1920, that was a criminal behavior. So all the people who drank at that point were criminals, and they were criminals up until the repeal of prohibition in 1933. So, and what grew up around that is you created a whole underground economy around alcohol. So we do the same thing with drugs because drugs are criminalized. You create a whole criminal economy around the manufacture and distribution of drugs. You drive the price up, you drive the quality is variable, leads to massive overdose deaths. You should know that in this period of time of COVID-19, the shelter in place in San Francisco, more people have died of opioid overdose than have died from COVID. So you create this really by criminalizing it, you create criminals, you create criminality and criminal behavior. You create, you remember the gangsters of prohibition. It's no different now. The minute you decriminalize that, you now have less crime. And I think it may sound different. It's not a crazy idea. Portugal did it. So Portugal decided to decriminalize drugs and instead used a public health approach to drug use. There's no increase in crime, no increase in violent crime, no increase in drug use, no increase in overdose. In fact, all of those things went down. So, and they did that quite a while ago. So that's been researched over a period of years. You even have, Canada is looking to add dispensed heroin in the same way we dispense methanol, because in that way people are not using the incredibly more dangerous tainted drug supply that we have today, which is tainted with bootleg fentanyl. So like we create a system that we then create an entire prison structure to respond to, and we create an entire way of policing. I mean, it's deployed in policing Black and brown people. It is just like incredibly tied to that. Every traffic stop of a Black person is under it's under the guise of, oh, your taillight might be out or you didn't signal, but let's search your car because we're looking for drugs. And every single one of those contacts could result in the death of that driver or the people in that car. So, like I said, crime is something we create by deciding a group of people are doing something that's criminal.
Well, thank you, Vitka. Let me ask a follow-up to that. You talked about innovation. You talked about the treatment alternatives, and I'll press you a little bit here. Some of these concepts are controversial. You're talking about paying people to stop using drugs. Tucker Carlson, or you name the host, if they haven't already, they probably already have, but they have a field day with something like that going on in San Francisco. I have to ask the question, how do you respond to that? What is the data? What can you share in addressing legitimate questions out there?
And luckily, we don't look to Tucker Carlson on what's effective for science-based interventions for substance use treatment, because we are in the healthcare world and we do our work based on science and evidence and research. We do, and we have to go with the research even if it defies logic. So there is a strong body of evidence and studies that have been replicated many times that intervention called contingency management, in which you pay people for not using drugs, it's effective. It's particularly effective with people who use methamphetamine. And we were involved in a study with UCSF quite a few years ago. That was a contingency management project in which we paid people, and it was through urine testing. We paid people to not use meth, to use less meth. And guess what happened? They used less meth. They even stopped using meth. I mean, it was stunning, actually, because even I was a skeptic. I mean, we were involved in the research project. I was like, what? It wasn't a big, in that particular study, there wasn't a big treatment intervention, and it was a significant reduction in methamphetamine use. So it may, science may take us places where we think doesn't make sense, but if there's a significant body of research, we follow it. It's not, politics may say other words, but we'd have to do the right thing for the people we serve.
Well, thank you, Vitka. And you mentioned politics, and I see that the Q&A is lighting up here. So thank you, folks. Hit that chat button and get the questions to me. I'll keep it rolling. So again, we'll press you a little bit, Vitka. But this from Diane Ireland, and the question is, how does the initiative of defunding the police play into all of this?
So I think, I think the term defunding the police, it's a fraught political term. And I think that what most people mean when they talk about defunding the police is that over the years, we have spent more and more money on policing, and so the police are the first line of intervention for things that don't require police intervention. And if we had taken, and not to mention militarizing the police, right? And you saw my statistic on the SWAT teams. And so it takes a lot of money to buy equipment and to like have SWAT teams have all the military equipment that they have to do their job. What if we took some of those dollars and did something else with it? And in San Francisco, what we're looking at now is what else can we do both to intervene in mental health crisis or substance use crisis in the moment, but also on the upstream end, what are the things we can do to prevent some of those crises? Can we use some of the dollars that we've used to call the police on people to do other things? Because that's not what police are for, right? I mean, and it doesn't work out well. The murder of Daniel Prude in Rochester. That was a man who was a black man, unarmed, who was having a mental health crisis, who his own brother called the police because he called 911 because he was scared for his brother. And so the police came, and his brother ends up being asphyxiated by the police. That's not the best use of police, and it's not the use of the best of our tax dollars for that. So, we are actively advocating to move those dollars into community-based interventions, community-based services, upstream interventions, so that we don't end up using police for things that you could use peers, social workers, youth workers, community outreach workers to do all of that kind of work. There's some models that are very effective. There's a program called Cahoots in Oregon, I believe, and where Cahoots is a non-police intervention for people in mental health crisis. It's a fair amount of research that supports its efficacy. So we talk about defunding the police. That's really what we're talking about. We don't think it's the best use of dollars to let's train. This is what's happened before. Let's train the police to be mental health interventionists. Let's use mental health interventionists and peers for things that they can actually do.
Yeah, thank you, Vitka. And it's a helpful clarification that you make there that I think leads to, I'm going to combine a couple questions that have come in, Bruce Armstrong and Linda Smart, where they are orienting the discussion around solutions. Bruce asked, what's the best way for us to help improve this situation? And Linda, how can the laws be changed? What can we do to change these systems that are no longer working? And I don't know, Vitka, if you want to speak to the region here in San Francisco or the state or nationally, but solutions, what are they?
I mean, I think that we do have to demand accountability, in terms of our elected officials, in terms of where resources are deployed, and are those resources deployed in such a way that supports people's health, and that would therefore avert policing. I think it's important to have conversations around decriminalizing drugs. I know that that's a very hard, that may be a hard notion for people to wrap their brain around, but look, Prop 64, that was a ballot initiative. You as voters, you may have voted for it or not voted for it, but just know that prior to Prop 64, if you had marijuana, cannabis in your possession, you were a criminal. Today, you can have cannabis in your possession in California and you're not. And so you have the power of those kinds of things and how that changes people's lives, how that you've now hasn't necessarily made more people use cannabis. It's just meant that people aren't criminalized for it. And the criminalization of that was, again, deployed much more frequently on Black people than it was on white people white teenagers who are using cannabis. So advocating for policies that move us away from the criminal justice system, that really question and challenge that notion. Advocating for low barrier services. I like to, I use this little factoid because I think it's important to note that in this country, about a little over 20 million people have problematic substance use. 20 million people. 2 million get treatment, seek treatment and get it. 1 million seek treatment and they can't get it. But the other 17 plus million people don't seek treatment, yet they may have highly problematic substance use. And I think that's the spot that we have to do something about that group of people. Everything we're doing now is effective for the people for whom it's effective. And it is effective. I mean, the work that we do is about as effective at managing the condition of substance use disorder as we are at managing diabetes and asthma, hypertension. But it works for the people. It's that effectiveness number hasn't changed much. It's that 17 million. So you want to do something about that 17 million people, we have to advocate for low barrier services. There are still places in this state where there's no needle exchange programs, there's no syringe access programs. We have to advocate for things like drop-in centers. We have to advocate for supervised drug consumption, because we see these as not only life-saving, but we see these as alternatives to policing and ways to make contact, like connections with people. And through those connections, they move to care.
Yeah, thank you, Vitka. And I've seen your work up close. It is absolutely incredible what you and your team do. I've been fortunate not until my involvement with HealthRIGHT 360 to see the ravages and the pain of addiction up close like this. And I have to ask, when you talk about the harm reduction, how's that not enabling?
Yeah, that's a common, it's not an unusual question when we talk about things like needle exchange, syringe access programs, or supervised drug consumption, or even decriminalizing drugs. How are you not enabling? And I say, first of all, like I said before, everybody, we're good with the people that we do well with, but what about the people we're not reaching? We can't keep doing the same things we've been doing and expect to do something different. I worry about that 17 million people, some of whom are dying in record numbers. By the way, the opioid overdose numbers have ticked up nationally again, and they have definitely ticked up during the COVID-19 period. And in San Francisco, the period of time we sat on the mayor's task force on supervised drug consumption, which I think feels like 4 years ago. And at that point, we have 22 overdoses in the city. So we were advocating the 22 overdoses. We were advocating because supervised drug consumption was still good, because we thought overdose numbers could go up and begin to match what you saw in Pennsylvania and Appalachia. We're advocating for it because it was also about moving people off the streets, connecting them to care, there's lots of public drug consumption in San Francisco. Could we maybe do something? Could we do something about that through supervised drug consumption spaces? Well, today, that number has, from like 4 years ago, it had gone up to 440 deaths, and I think it's approaching 800 this year. So, I mean, that's a crisis, right? And so we have to do things, harm reduction services is not enabling. It's just engaging people. We can't make people more miserable. Those of you who are in the Bay Area, like, you've seen people living on the streets. You've probably seen people using their drugs on the street. Those people are living in misery. So locking them up, making them live outside, all of those things doesn't drive people into treatment. Connection and hope is what drives people into treatment. And when I talk with people who've been in recovery, and they look back on their own recovery stories, and they think it was tough love. You hear that term, tough love, that got me there. And I always say, no, I think it was the love, not the tough, because they'll always find someone in their story, if they really think about it, who saw something in them, gave them some hope, and it was the hope that moved them into into health. It wasn't the people yelling at them or shaming them. Shaming keeps people in misery. So it's, you know, we're Haight-Ashbury Free Clinics. We're born in the summer of love. It's the love that moves people into care.
Right, right. And just to follow up, Vitka, the supervised consumption sites versus these sobering centers, we have both in San Francisco, I assume, or I guess. What's the difference?
Good question. We don't actually have a sanctioned supervised drug consumption site anywhere in the United States. There's 100 of them around the world, but there's none in the United States. San Francisco, there are some unsanctioned sites that exist that we already have research that shows they've reduced the number of people who overdose. But supervised drug consumption sites are places where people bring drugs they have obtained elsewhere, and they come to a place and they use them under the supervision of trained peers and or healthcare workers, and that they do it in a sterile and clean environment that often has other services attached, and people make sure they don't die and that they're not in no way injured. In a sobering center, people use drugs elsewhere, who have used drugs elsewhere. We attract them to come in and come in, and we're with them until they sober up or stop being so high that they're spinning around out in the street. So we have sobering center. There's a sobering center in San Francisco. It's a alcohol sobering center. It's been around for quite a long time. So people who are passed out on the street can get kind of picked up and taken by this vans that run from one of our community-based organizations, picks people up, takes them to the sobering center, lets them sleep it off, and they can leave. There's other services attached. The city had proposed that we operate a sobering center that was focused on drugs and drug use. They were particularly targeting methamphetamine use because methamphetamine use, people who use methamphetamine for a long time and lots of it, can appear on the streets. There's some behavior, problematic street behavior, people who are talking to themselves and they're kind of tearing their clothes off, things you might look at and think that person is schizophrenic, is actually just hasn't slept in 5 days and has been on a long meth run. And so a place where people can come and we can, just help be with them and, give them some place to sleep when they come down, a shower. So we had a plan to operate one. We specifically said we did not want it to be one that was, people were brought there by the police. That was our condition, that we said, we'll go get them, but you can't make people come. That would defy anything we think is the right path forward. And it would also, like, imagine if you have somebody who's like spinning on meth and they're brought into a place with other people on meth and they're brought in handcuffs, you can imagine that would be pretty intense. So we said, no, that we can make this work. We can really make this work in another way. And then COVID-19 hit and the funding got cut. So we're still talking with the city about it. Prop C, I think you might, those of you who are from San Francisco know that the courts cleared Prop C, which is a tax that will increase revenue for services for people experiencing homelessness. Prop C cleared yesterday. So hopefully we'll be talking about a sobering center soon. But it's like weirdly ironic because the sobering center is not a drug consumption space. So people can consume drugs outside of it, but they can't come in and use it, and then you sober them up. It just doesn't, it's like the strangeness of American law and policy sometimes. You spend a lot of times policing bathrooms to make sure that people aren't overdosing in the bathrooms instead of bringing them out somewhere where they could be safe and make sure they don't overdose. But we'll get there. I have faith that we will get there.
I got a couple follow-ups that have come in on the Q&A. Are the supervised drug consumption sites not legal? Is that why there are none in the U.S.?
It's not that they're not legal. It's that the Department of Justice has decided that they would fall under the crack house statute, which was a law that came about during the period of where there was lots of crack use. Crack house statute says that a landlord or business or you're responsible for if you know that people are consuming drugs in your space, and so they would apply those laws against landlords who had what were called crack houses operating. And so when they tried to open one in Philadelphia, the DOJ immediately sued them, and it went to court. and the judge found that it was not a crack house, that the crack house statute did not apply, that it was in fact it was a public health response to a public health emergency. But then the Department of Justice appealed. And the fear that I think organizations and municipalities have of doing it without there being some legal cover, and California, we were advocating for a state law that would provide some legal cover. The concern is that could you face harassment from the Department of, could your participants face harassment from the Department of Justice if they thought it was a crack house? Could the landlord, have their assets seized because they were operating a crack house? And could your licensed professionals, and so the state law was really there to protect the licensed nurses who might work there, would their license be challenged in some way? So it's not, we believe it's not against the law. We wouldn't be advocating for it, but you do worry that the Department of Justice would aggressively pursue it otherwise.
A couple questions now, shifting to housing, homelessness, referrals to HealthRIGHT 360. Joanne McManus, what's the process for an average person who lives around homeless, drug-addicted people to refer someone to HealthRIGHT 360?
So anybody could walk in the doors of our facility in 1563 Mission, which is Mission and Corner Mission in South Van Ness. That's our central intake. Anybody could walk in there Monday through Friday from 8 to 3 and seek treatment, and they'll be seen and they'll get an assessment, and we will seek approval from the county to pay for their services. And ideally, we frequently can get people in on the very same day. Sometimes it's complicated if they don't have Medi-Cal yet. So we're still going to get, most of the time we're going to get them in on the same day. And so it's just telling them that they can come here. But reality is most people who use drugs in San Francisco and who are living on the streets know us. We have a street outreach team that goes out, and we're the largest provider of substance use disorder treatment for people on Medi-Cal and people without insurance in San Francisco. We have, 500 people in either a treatment bed or a transitional housing bed every night. So people know we're here, but you can always send them. Like I said, the problem is not everybody wants what we have, so we have to give them what they want, and that we need the city to permit us to do that. We need low barrier services. People come in. I had a conversation there's a reporter who follows substance use treatment a lot, and she was surprised when I said, not everybody who comes to treatment, like they don't want to necessarily stop using drugs, they just don't want to have miserable lives. And so is there a way that we can accommodate that? Like, why do we force people to live outside in a tent and make them move their tent every third day or something like that? Like, we can do better for people. And then we can be there for them without judgment and compassion. And if at a point in their life they want to do something else, they'll trust us and they'll come to us and we'll be here. So.
Bruce has a follow-up. Bruce Armstrong, has HR 360, has HealthRIGHT considered an Uber or Lyft program to allow people to give others rides to HealthRIGHT 360 clinics, or a voucher program, for example? It's an interesting idea.
It is an interesting idea, actually. It is an interesting idea. No, there's the people who run the van for the sobering center, in theory, could bring people to us, the community-based organization. But it is an interesting idea, Bruce. I'll have to think about it.
And Diane, a member of our board, Diane Ireland, a follow-up related to public housing. Vitka, can you please explain the comment that people with convictions are excluded from public housing? How does this happen, and what is the impact?
So some of the public housing policies are decided community by community. Like there's community public housing, although funded by the feds. There are some local rules around it. So what happens is a person who has had a felony drug conviction may not be able to access public housing, may not be able to live there, even if their mom lives there, like, and they're going to come back to live with their mom, they might not be able to live there because they're seen as a potential risk to the housing environment. And so those are policies that exclude people. They're just discriminatory policies based on people's drug histories.
Let me ask you here, Vitka. It's coming up on 6:20, and I want to make sure the question is posed to you around diversity and inclusion, Black Lives Matter. For those of you out there listening who have not read the statement of HealthRIGht 360 on Black Lives Matter and diversity and inclusion, you really should. It is one of the most direct and open and powerful statements that I've seen. I was so proud to be affiliated with the organization around that and reading that. And Vitka, I just want to ask, the words were great. What are you doing? What are you doing in the community? What are you doing, externally and internally around diversity and inclusion in this very difficult time?
That was exactly why we put the statement out, Ahmad, is to be held accountable. We wanted to make a strong statement and be held accountable by our community, by our board, by our staff, by our clients, because of that complicated and sometimes complicit history of drug treatment programs in the criminal justice system, and the whole impact of drug laws on the racist drug laws on our clients. Majority of our clients are people of color, and in fact, so are the majority of our staff. We have a very, very diverse staff. And so when we look at what's our program and our commitment to equity and anti-racism, we look at it from a top to bottom approach. We have a steering committee made up of an amazing group of staff members from different parts of the organization, really diverse in every sense. And that committee is charged with developing our work plan on equity and anti-racism and inclusion. And that work means looking at what's the composition of our board, what's the executive, who are executives, what's the composition of the executives, what is the, kind of the knowledge base of our board and our executives and our leadership team on equity and racism in this country, and doing anti-racist work within the work that we do. What's our hiring practices? What are our, promotions, terminations, disciplinary practices? What clients do we deal well with? What clients stay in treatment the longest? Which clients get, asked to leave the program? What are the health impacts of the services that we're doing with different population groups? And how do we make change to that? In addition to that, what are our policy positions, and how do we advocate for more equitable and just policies that act, to redress really the harms that have been done to Black people and other people of color by the drug laws. So we put the statement out because we want to be held accountable and because we have work to do.
Well, Vitka, you heard from Linda Smart on our board, from Diane, me as a board member, Brian. We fully support all of your effort and work around diversity and inclusion, all that you've been doing, taking very hard looks at your board, at your staff, as you mentioned, and walking the talk. I would ask you a personal question. I'm sure most on the line know your story, and really going full circle from being a patient in the clinics to now leading the clinics you oversee. What is the secret to overcoming addiction? Is it one item that you pinpoint? Is it one day where you say this is it, and it's going to be different? What can you share about that?
I mean, I think the most important thing is to have a connection and to have somebody who has hope for you and belief in you when you don't have it in yourself. And I think that's a consistence, you would find that for so many people. It certainly was for me. I was a patient at Haight-Ashbury Free Clinics, outpatient heroin detox program. I probably went through the detox like 9 times, right? Which meant that I would detox, then I would go back and I'd be using it again, I get strung out, and I come back and detox. And like, I went to the detox because they never ever said, like, they were never cynical, they never said, oh, you're back again. It was always like, hey, it's great to see you, how you feeling? Let's look, we missed you, what's going on? And so because of that, I just kept coming back. And then at a point in my time in which I needed to do something different. I was like, I was homeless. I was at my wit's end. I just was sick and tired of it. And I just, I went to them and said, what should I do? Like, I don't know if I can keep doing this. And they said, you should go to Walden House. So I trusted them. So I went to Walden House. And that's, I went through Walden House, and I have not used drugs since then. So, and in there, same thing. It was like people who it wasn't like, it was the loving relationships that I had with people there. That is what, it's what helps people heal is connection, and like people just being there for you, and believing in yourself, and when you don't believe in yourself. So, and not putting a timeline on what that looks like, right? Not putting a timeline on that. So, I mean, that's for me, but I also think, having watched so many other clients, and I've been doing this work for 30 plus years, it is, I'm always happy when I see clients come back. Like, I'm always like, hey, and they're so embarrassed. They're so full of shame. And I'm like, oh, I'm so happy to see you. Because I really am, right? Like, I'm happy they're alive, and I like them, and I want to be in a relationship with them, so I want to be in connection. So I think that's so critically important to the work that we do. I mean, there's plenty of research about what kinds of interventions are effective, for sure. But people don't, my favorite little piece of research is that they studied a bunch of different interventions, and they found that the biggest effect size came from the person delivering the intervention, not the actual intervention. So contingency management works, and cognitive behavioral therapy works, but they work best when delivered by empathic people who are compassionate, and that's what works.
Well, Vitka, we've got one more question that's come in, and 5 more minutes. Bruce, and thank you, Vitka, for sharing your personal experience in that story. It is really inspirational. And we'll close here with Bruce. Bruce Armstrong, why hasn't San Francisco more fully adopted the new the conservatorship laws? What has prevented those laws from being adopted? What thoughts do you have around those laws, generally speaking?
Well, we took an opposed position to that. The new conservatorship law was an expansion of an existing conservatorship, which has already existed for people with severely impaired by mental illness, and severely impaired by late stage advanced alcohol use disorder. And it expanded that to include drug use. It was really targeting, I think, people who use meth. And so while we have been working towards, we have to try other interventions. We have to be more creative. We have to stop relying on coercion. It's such an easy thing to fall into, and it's so potentially harmful to people. And I was concerned about the slippery slope of essentially committing people to treatment. So now we're not telling them you have to go to treatment instead of jail. We're telling them you have to go to treatment until what? You end up locked up on an institution of some kind. So I think, you may disagree, but part of the reason it hasn't been fully implemented is because advocates, of which we are one, have said, boy, slow down. Let's give us a chance. Give us a chance to let's try the different things first before we fall on that thing. And I get it. You have kids who are struggling with addiction. You will do anything to make sure that they don't die. We don't want kids to die either. And we think there's alternatives that we could create that don't require locking people up one way or another.
It's fascinating, Vic, and we could go on and on here. It's a subject that you have such experience with. Your work is so impactful. And so many of us find it just so interesting in trying to come up with solutions. But as our time here comes to a close, I want to make sure to thank everyone for attending our first Insiders Update. The event was planned to keep our closest circle of supporters and potential supporters updated on our work at the front lines. If you would like to be involved or more involved, or if you have any feedback for us, please contact Shabana Siegel, our VP of Philanthropy, at donate@healthright360.org. Vitka, again, thank you so much to you and your team. You do incredible work out there on the front lines. Thank you, everyone, once again, for dialing in this evening, and have a great night.
Thank you. I really enjoyed the conversation, everybody.